For the Pew Charitable Trusts, I'm Dan LeDuc, and this is After the Fact. Our most recent season focused on race and research, and in one of our episodes, we heard from Dr. Marie Bernard, Chief Officer of Scientific Workforce Diversity at the National Institutes of Health. We couldn't cover all the ground we wanted to with her then, and so we thought you might like to hear more from our interview as she explains why diversity matters in medical research, not just among the patients who are being studied, but among the doctors and scientists doing the studies. And she tells us what the NIH is doing to improve that. Dr. Marie Bernard, thank you for being with us. You lead the Scientific Workforce Diversity Initiative for the National Institutes of Health. Let's talk about that and the role of diversity in research. Why does it matter?
Diversity matters because we have really good evidence that when you have diverse groups of people working on various problems, you end up with better answers, more creativity, more innovation, and we as a science agency are all about that. So it's really important to us to make sure that the workforce that is trying to solve the nation's health problems is a truly diverse workforce.
If I could, I'd like to just ask you a little bit about your own personal experience. You're a woman of color who entered this field a long time ago, not that long ago. Tell us about how you got interested in medicine, maybe the challenges you had initially. And again, since the questions that researchers bring are based on their personal experience, how do you think your personal experience has influenced the work you've done that way?
So I got interested in medicine when I got into college. I went to college planning to be a French major, but my French with an Oklahoma accent didn't cut it. But I did really well in chemistry and ended up saying this is the direction that I want to go because I liked the people contact. This was as things were beginning to open up for women and for people of color, so that when I entered medical school, I was in the largest class of women at University of Pennsylvania to that point. When I entered college, I was the largest class of Black women at Bryn Mawr College. And as a result, you run into things because you're the first. I would frequently, when I walked into a patient's room, be mistaken for the nurse or the ward clerk. So I would routinely say, "Hi, I'm Dr. Bernard," before they had a chance to make the mistake. I would frequently be singled out for questions because there's no hiding. I was different from the rest of my classmates, but that made me stronger and better, I felt. I had the experience when I was a resident that I was in charge of the emergency room, and I happened to have an African-American student working with me that evening, and a patient who didn't want to see me or my student. And had the pleasure of saying, well, you see us or you don't see anybody. So, those are things that happen. I would like to think that those things don't happen any longer because there are many more in the field. It's not so unusual to see a Black woman as a physician. But I do know that there continue to be microaggressions that people have to endure. And unfortunately, sometimes there are still overt aggressions, and we need to continue to work to eliminate those sorts of things.
You, of course, have had a choice, though, in your career. You're a very accomplished professional, and you could have chosen to just go ahead and sort of do the research and taken on the issues of aging and ask the appropriate questions about diversity because of your background. But you've added this element and interest of diversity to not just how you do your work, but that it is part of your work. And why did you choose to do that?
So I chose to follow up on my interest in diversity because that really has been woven into everything I've done throughout my career. From the time I was a young faculty member at Temple University School of Medicine to then being a faculty member at University of Oklahoma College of Medicine, I ended up, in addition to my teaching and research, having administrative responsibilities and always having an eye to making sure that there were diverse individuals as part of it. I felt a responsibility, an obligation to bring others along. Never really wanting to focus exclusively on this because certainly at that time, having that as your exclusive focus was kind of a career ender. So I did do the research with regards to aging. My focus was on nutrition and function in older populations, particularly ethnic minorities. But as I got to NIH and took on a true administrative role, exclusively administrative role, administration of research, but administrative role, there was the freedom to really focus much more on these things. And so got involved in things like co-leading what's called the Inclusion Governance Committee here at NIH that looks across NIH to make sure there's appropriate inclusion of women, underrepresented minority groups, children, older adults in clinical studies. I got the opportunity to lead what's called the Women of Color Committee of the Working Group on Women in Biomedical Careers. And our job has been to look at that intersection between being a woman and race ethnicity in success in science. And so we've been systematically working on elevating the presence or elevating women to the attention of those who are in leadership roles, such as having them as speakers in our lecture series here at NIH, such as setting up networks to connect people virtually. And when asked to step into this role as the acting chief officer for scientific workforce diversity, found it just to be the natural. It just brought everything together that I was already doing.
So how did the National Institutes of Health begin to even discuss this problem, begin to work on this problem? Is this a recent thing, or has there been a recognition maybe over time about the need for this?
So the National Institutes of Health has focused on issues with regards to diversity for a while now. There have been policies in place to assure that there's diversity of participants in various clinical studies. In 2011, when Donna Ginter and colleagues did an analysis of the success rates of various groups that are usually underrepresented in science getting grants from NIH, what's called R01 equivalent grants, they found that the various groups tended not to have the same success rate as non-Hispanic whites. And in fact, when you controlled for all sorts of factors, English as a first language, education, the institution a person came from, that there was a persistent disparity in receipt of these R01 equivalent grants for African Americans and Blacks. So prior to those controlling factors, Hispanics, Asians, American Indians, Alaska Natives all seemed to be at a disadvantage, but there was that persistent disadvantage that was seen. And thus the NIH director, Dr. Francis Collins, turned to his advisory committee to help to think about how to address this issue. And the advisory committee came up with a number of recommendations, one of which was to establish this role of chief officer for scientific workforce diversity. The first chief officer was Dr. Hannah Valentine, who came on board in 2014. I've been privileged to step into that role as of October 1 of 2020.
Of course, when we're talking about who gets grants, that's really just one prism of the issue, right?
Yes.
Let's broaden our discussion. What are all of the various facets of diversity in research, and how do they come into play?
Thank you for asking about the various facets of diversity in research, because that allows me to talk about an additional initiative that NIH launched February 26th of 21 that we're calling Unite. It's an initiative to address issues with regards to diversity of the scientific workforce, diversity of the administrative workforce that supports the science, the diversity of projects, particularly projects that are focusing on health disparities, minority health, and health equity. And it is our goal through this initiative to really make a difference for the barriers that diverse scientists often run into in getting their research supported, to really make a difference in the health of our nation. We have seen, unfortunately, as a result of the COVID pandemic, that certain populations have been more disproportionately impacted than others, particularly African Americans and Hispanics. And we know from our research that there have been persistent disparities in health for those populations and others that are considered underrepresented. And our goal is to better address those sorts of issues, to make sure that the people around the table asking questions and supporting the asking of those questions are truly representative of the diversity of our population. If we're going to maintain our leadership role in science, it's really critical.
I want to keep going on some of those big picture issues, but since you brought up the pandemic and the impact on African Americans and maybe some other minority groups, let's just take a moment and talk about what that impact has been, because I think it's probably front and center mind for people right now. Let's help them understand when we talk about diversity and impact, how we were able to figure that out during COVID. What were some of the preliminary findings of why it was happening? So, I mean, those are the sorts of questions that get you to solving the bigger problems, right?
With regards to the pandemic, we were able to see pretty quickly that there were certain populations that were getting hospitalized more frequently and dying disproportionately as a result of the pandemic. Older adults, individuals from what are considered to be underrepresented racial and ethnic groups, individuals with multiple chronic conditions. And as we're now hopefully coming out of the pandemic and we're seeing people getting vaccinated, we're seeing disparities there related to access to vaccines, related to concerns about trust with the medical establishment. So we at NIH have tried to work on this on both ends. We established an initiative to focus on underrepresented populations in terms of researching interventions and vaccines, in terms of making outreach to populations to get them involved with the research. And now we're working with CDC and others to try to make sure that accurate information about vaccines is out there and that people are given adequate access.
You talk about sort of both ends of the problem. There's the impact on patients who may or may not be getting the kind of treatment that it could be available to them for a variety of reasons. There's also the beginning of the process, which is what gets researched. Who does that research? How do we get started on the workforce?
So for the scientific workforce, what we're seeing is some promising things that when you start looking at children in high school, and as they're making the move from high school to higher level of education, you see great diversity in the population, representative of the way that our population demographics are evolving in general, and great interest in science. What we are running into, however, is that at every stage on the pathway to becoming a scientist, those numbers and percentages go down, so that you may start look at people at the community college level, and as they're entering a great deal of interest in science, you look at people at the point at which they become a director of a department or what's considered a senior scientist, and there's very little variety in the people who are there. And at every step of the way, there have been decreases. What we know as well, however, is that the sorts of questions that people ask in science relate to what their personal experiences have been and their interests are, and those are going to vary. And many times, the people who come from what's considered to be an underrepresented group may have a different sort of question and focus very specifically on that group that just may not have gotten asked by other scientists. That's why it's so very important to have a variety of people at the table. And then when it comes to actually executing the study, particularly if it's a human study, we find that scientists from diverse backgrounds are often more effective in recruiting people who look like them to be involved with clinical studies than when you have a more homogeneous group of people involved with the recruitment of people into the science. Part of that gap that I was talking about that Ginter and colleagues were demonstrated in 2011, there have been a lot of additional analyses since that time. And one of the things that has been found in the last year or so is that, for instance, African American and Black scientists, almost half of them focus on topics that are in a very circumscribed area, much of it being health disparities, health equity, minority health research. You see that with Asian scientists, Pacific Islander scientists, with Hispanic scientists, with people living with disabilities. The sorts of questions that they will ask many times will be very different than a person who's not had to live with a disability. And all of those things are helpful to us to get a sense of the total health of the nation. That doesn't mean that those are the only people who are asking those questions, but there tends to be a higher attraction of those sorts of scientists to that area. So For all of those reasons, the decreasing numbers over the course of time, the importance of the questions that are asked, the importance of having people to recruit people into the studies, you need to have a variety of people at the table.
You spoke about the NIH sort of grants that are in one way a benchmark of how well we're doing in this. Was it the question that there weren't enough diverse scientists in the first place? Or was there less attention being given to sort of the issues that they wanted to study maybe a couple decades ago?
So the question of why there has been this gap in funding for particularly African American and Black scientists has been one that many people have wanted to answer, and it appears that there are multiple factors that contribute to it. Part of the problem is that the numbers are small, although growing. Part of it is the area of interest of the scientists may not match well with what gets funded at NIH. There's been a recent analysis done by Dr. Mike Lauer, the director of our Office of Extramural Research, that looked at the same sorts of data that Ginter and colleagues had looked at back in 2011 and that subsequent researchers have looked at. And they found that the topics of interest of African American and Black scientists track with a lot of them, just 5 or 6 out of our 27 institutes and centers. And 5 of those 6 have less money available to them. And so the success rates for applications to those institutes is lower than the success rates to other institutes. So it's multiple factors. And we at NIH are working in multiple ways to try to correct those sorts of problems.
I was struck by a phrase on the website of your initiative at the NIH. We all have heard that expression, great minds think alike. And you guys have added the phrase, great minds think differently. You've mentioned that there's data and research that supports that notion. Could you go a little deeper on that and help us understand that?
I'm happy to talk about the data that shows that diversity makes a difference. There's a lot in the business sector, and there's a growing amount in the scientific sector. In the business sector, you can, for instance, have individuals involved in mock reviews for law review and evaluate the quality of the decisions that are being made and demonstrate that when you have a diverse panel versus a fairly homogeneous panel, there's more information that's brought in that could be considered the ideal approach to the problem. When you look at people who've done work in the stock market and look at homogeneous teams versus heterogeneous teams from a diversity standpoint, the more homogeneous team ended up paying more and getting less return on investment than the heterogeneous team. It's kind of almost like there was a group think of the homogeneous group. So they drove up the prices and paid a lot more for the stock than they needed to. In the scientific arena, we have research that demonstrates that when you look at the diversity of a scientific team, whether you're looking at that diversity based upon seemingly race, ethnicity, based upon name, or looking at diversity based upon the geography of where the individuals come from, or look at diversity based upon the number of other citations that they've brought into their planning, the research leads to publications that is more impactful when you have a diverse team versus a very homogeneous team. And that seems to be over and over again that we're able to demonstrate those sorts of things. So that's a reason to really pay attention and try to make sure you have a lot of different viewpoints.
So if we're looking at diversity in this world, we have to look at the workforce, the doctors and researchers. And of course, part of it involves trials, clinical trials of drugs or other treatments. You want to make sure that that pool of people who are part of these studies represent the true diversity of the population. How do you do that?
So diversifying clinical trials is an art and a science. And there are multiple things that need to be considered. You need, as you're designing the study, not to have so many reasons a person can't participate that you end up excluding various populations. Like many times you end up excluding older adults because people can't have lots of other illnesses or can't be on lots of medications. That's just as applicable as well to what's considered underrepresented minority groups here in the United States currently. African Americans, Hispanics often have multiple chronic conditions. They're on multiple medications. They may have some mobility problems, just as older adults may have some mobility problems. So you need to design the study in a way that you don't end up just excluding those people. You also need to be prepared to make much more aggressive outreach than might otherwise be the case. Just putting ads in the paper, or I don't think people read papers anymore, but just doing ads is not sufficient. You need to make direct outreach to where people are. For instance, with the NIH efforts to overcome misconceptions about COVID-19, going to barbershops, churches where African Americans tend to congregate are some of the things that have proven to be effective. And then you need to structure things to make it easy for people to come in. Sometimes people aren't going to have transportation. People are trying to work in spite of the pandemic, having hours that will allow people to come in. Something that's structured that requires people to get on the internet and respond to multiple questions, etc. For many people who are from underrepresented groups, the internet access is not necessarily optimal. So you kind of end up excluding them based upon that. So you just need to be very mindful and think about who is this population that may be difficult to recruit. What do you need to build in that will allow you to make that outreach?
Are there examples in the scientific or medical world of research that maybe was focused on a minority population that opened our eyes to something that was true for everyone?
Thank you for asking that question as well. It is important to recognize that when we talk about health disparities, minority health, health equity research, it's not just because it's the right thing to do, it's because it allows you to see the problem more clearly scientifically. A great example of that, one of the hats I wear is as Deputy Director of the National Institute on Aging, and we lead for the federal government research with regards to Alzheimer's disease and Alzheimer's-related dementias. And much of the research in the early years was done on very homogeneous populations, generally a high socioeconomic status level, non-Hispanic whites. And we've been able to discover that there are a lot of genes that are associated with the development of Alzheimer's disease. However, as we have broadened the participation and brought in Asian populations and Hispanic populations and African American populations, we found many more genes that are associated with Alzheimer's disease, giving us the hope that with this broadened group of genes that we can look at, we will find a means of preventing or treating this illness much more rapidly than when we had the more restricted panel that we were looking at. Similarly, my recollection is that with regards to treatment of hypertension, there was a standard way of going about the treatment of hypertension. As experiments were done to look at the impact of various drugs on African Americans, it was found that other types of drugs were more impactful for African Americans, but they also had benefits for other segments of the population. So it is the just and right thing to do. It does lead to greater creativity and innovation, and that creativity and innovation is applicable to all. It leads to generalizable principles, a much better understanding of whatever disease state you're concerned with.
What about the category of the African American community, others who have been underserved, and this notion of trust with the medical community? There's part of me that wonders if that might be one of the bigger challenges at this point. If we're making good trend lines along the way, when you look at the track record for a lot of the communities involved here, you can understand why trust is going to take a lot of work to regain.
Trust is a big issue when making outreach to the African American community, the American Indian community, and others. And it's something that is hard won and easily lost. And we have a very poor track record, unfortunately, here at NIH. The tough part of building trust is it takes time and it takes energy, and it's really kind of a one-by-one sort of thing. I'll tell you the story. When I was a young faculty member at University of Oklahoma, I grew up in Oklahoma, my childhood friend who was a faculty member at another university in the area and I decided we were going to go and do research among the African American population that lived just off of the OU Health Sciences campus area. I'd grown up in that area. And we were going to do this study on nutrition and function in the population. And even though we were African American, making outreach to African Americans in the neighborhood where we had grown up, they were not welcoming to us initially because we were part of the establishment. My colleague and I sat and met with representatives of the senior living complex, asked them, what are your needs? Their response was, people come in, they do research, and we never hear from them again. Or, I'm not sure exactly what your research is, and I'm not sure that it's safe. Or, we need things, and we never get anything. So we addressed all of those things for the population. And similarly with the other initiatives, you have to sit down. You have to listen to what the group has to say and address it. Another outreach that I made when I was in Oklahoma was to Native American populations. We have lots of Native American populations there, but you don't just traipse into the tribe and start doing research. You talk with the tribal council, you talk with the tribal elders, you make it very clear what it is that you intend to do, you find out what their expectations are in terms of communications. It's a long process, and it is very much enhanced by having someone who lives within the community who is going to be your surrogate to say, this is a person that you can talk to. This is a person who's going to be trustworthy. So during this pandemic, NIH has been very cognizant of that. And we've developed a couple of initiatives to focus on underrepresented populations, to develop outreach to those populations. But you can't just all of a sudden make that happen. You have to work with people who are already embedded within those groups, who can be ambassadors, mediators, that sort of thing.
Well, Doctor, this has been a real pleasure. Before we let you go, I'm going to ask your medical prognosis on where we're headed, because if we are at this inflection point, as you believe, and you see some of these trends, what is your prognosis?
I am very hopeful. I see a lot of energy, enthusiasm, momentum propelling us forward, and really intently focused on being equitable in the approach to all. I think that as we develop initiatives to bring us to that point, we will find that we're having actually better outcomes from our research and moving that along more rapidly. And I am hopeful that we will, in the end, have new systems in place that make sure that every voice is heard, regardless of position, viewpoint, the dominant paradigm. And I think we're well on our way in that direction.
Well, Dr. Marie Bernard, thank you so much.
My pleasure.
Next up in our bonus episodes is our interview with Fanta Traore, co-founder and chief executive officer of the Sadie Collective, an organization that is encouraging Black women to enter the fields of economics, finance, and data science. For many of the same reasons, Dr. Bernard is working to encourage more diversity in medical research, because diversity among researchers produces more helpful results for all of us. We hope you'll listen. For the Pew Charitable Trusts, I'm Dan LeDuc, and this is After the Fact.